Está começando mais uma edição do Solver Talks, o videocast de entrevistas da PwC Brasil. Dessa vez, trouxemos uma das mulheres mais influentes na área de saúde pública, a Baronesa Nicola Blackwood. Conversamos sobre os avanços, impactos e boas práticas da sua empresa, a Genomics England, que trabalha com sequenciamento de DNA com foco em estudos sobre doenças raras da população. Falamos também sobre suas percepções durante essa visita ao Brasil, sobre esse tema da genômica aplicada na saúde. Confira! Hello everyone, I'm Bruno Porto, the healthcare leader for PwC Brasil. We are hosting our Solver Talks today on healthcare and specifically about genomics. We have a very special guest with us today, Baronesa Nicola Blackwood. Nicola is chair of Genomics England. She's also chair of Oxford University Innovation, a member of the House of Lords, part of the UK Parliament, and also in the supervisory board of BioNTech, the company that developed the mRNA technology along with Pfizer for the COVID vaccines. Very happy, Nicola, that we are here today. It's your first time to Brazil. We talk a lot about what you do and also get some perceptions from you on what you have learned here and what we can do better for the future in terms of genomics, getting lessons learned and your points of view as well. So Nicola, to start off our conversation, what's Genomics England all about? What have you been doing? Can you share with us a little bit of the work over these last, let's say, 10 years that it's been?
Well, thanks, Bruno. And firstly, thank you for having me. It's been a fantastic visit to Brazil, and I've really enjoyed meeting all of the scientists and innovators involved in genomics and healthcare. It's been a huge welcome and fascinating to understand many of the challenges and successes, which are surprisingly similar, though on a different scale than we face in the UK. I've learned so much already. So Genomics England began way back in, surprisingly, the London 2012 Olympics as a vision for an Olympic legacy. It was due to the Prime Minister, David Cameron, bringing together scientists and clinicians to work out what would be a legacy for the Olympics. And they told him the time was right for genomics to enter into healthcare. And so the vision for a program to prove whether genomics would work in healthcare was born. And that was the 100,000 genome program. And so Genomics England was set up to sequence 100,000 genomes of NHS rare disease and cancer patients. And this was a huge endeavour, and it involved 97,000 patients and families. It involved 5,000 NHS workers recruiting those patients, 98 hospitals, and many more, 3,000 researchers from around the world, and loads of data, as you can imagine. Just one whole genome is 200 gigabytes of data. That's a laptop's hard drive. So we now hold at Genomics England the largest whole genome data set in the world. But what happened once we finished recruiting the 100,000, which was in 2018, is we returned many results to patients. 25% of rare disease patients had a result, and there were many new discoveries. But we had the evidence base that whole genome sequencing worked for the clinic. This changed lives. It returned a change of treatment, an actionable result for 50% of cancer patients. And so as a result of that, the NHS Genomics Medicine Service was set up. And we now are commissioned as a standard of care for rare disease and cancer patients in the NHS, equitably accessible across the whole of the NHS. So from an idea at the Olympics through an enormous research project involving the whole of the NHS, we now have patients in the NHS eligible for genomic sequencing in a way that really changes lives materially.
Well, this is amazing. Great 10 years, and amazing that it has evolved to this, and it's still playing a very important role in the UK. Nicola, what types of real life examples of impact to patients and their families over these last years? You mentioned about 25% of identified rare disease cases in the sequencing. How that impacted patients and families in terms of treatment, in their diagnostics? Could you share with us some examples?
Of course. So we have obviously had a lot of patients who've had results. There was an early patient who had just one change, a single change in his DNA, and he had very unspecific symptoms, but one of the symptoms involved anemia. So he was very lucky. He got referred to a child hematology unit. He was only 5. And remember that 75% of rare disease patients are children and 30% don't live past their 5th birthday. And so he ended up being referred into the 100,000 Genome Project, and he was sequenced, and they found that change in his DNA was a mutation in the THRA gene. And other children with that change had similar symptoms. And it turned out he had a very rare form of hypothyroidism. And what's unusual about this is it's not about the level of thyroid in your blood. It's about how that thyroid hormone is taken up into your cells. And so when you have a blood test, it looks normal, but you still have the symptoms. And so it's very hard to diagnose in the clinic. But if you have the sequencing, it's very easy to diagnose. Moreover, it's very easy to treat with cheap and easy to get an affordable thyroxine. And so that was a great outcome for that patient. We also had another patient, Alex, who was undiagnosed for 18 years, and he had to have 28 operations on his heart and other areas, and he ended up being diagnosed through the 100,000 with a very rare condition, Leopard syndrome. Now, this is like a number of patients with rare diseases. That didn't give him a big change in management. There isn't a magic bullet treatment. He doesn't have a big change in his life expectancy. But what Alex and his parents said about that was it was a huge relief to at least know what the problem was and to be able to contribute to research and better understanding for other patients. And we hear that a lot from participants because only 5% of rare diseases actually have a therapeutic. So a big part of what we do at Genomics England is getting together the data set so we can drive more understanding and get better research to discover more diagnostics and therapeutics for rare disease patients in the UK and globally.
The process you explained, it's amazing. We looked at the website of Genomics England, and it's very well informed and a lot of good information on what you guys do. There is a specific graphic, it's the infinity loop, right, that you made reference to, which is very impactful. It's very clear in what you do. It has Genomics England in the center. And these two cycles, right? The cycle on the DNA sequencing and the impact and how it goes back to the patient, and then the cycle of the research and how all that data that you made reference to gets used as well for other purposes further. Can you explain to us a little bit this mechanic and how it works and how it's really impacting both the research and the cycle between the sequencing, the diagnostics, and the way the doctors and the physicians, they return that back to the patient and how the impact functions?
Of course. So, at Genomics England, our vision is genomic healthcare for the benefit of everyone. And so when we transitioned from being the research project into essentially a platform to integrate into the healthcare system, what we understand is that if we are going to create a service to improve healthcare for our participants, but also for the NHS as a whole. This will only work if we're continually replenishing the genomic data set, which we hold through research and innovation, which can return results to patients. So Genomics England sits at the X that you can see in the centre, and that is where we maintain the really precious genomic data set. and we have our tech support and analysts and bioinformaticians there. And you will have a doctor there who will see their patient, and they will order a test and take samples in the NHS. And then those samples will be sent to our sequencing labs at Illumina, and they will sequence that data, and then it will be returned to our bioinformaticians and clinically accredited biopipelines at Genomics England. And then we will return those to. We have 7 genomics laboratory hubs with clinical scientists, NHS clinical scientists across the country, and they will do the final analysis, turning those initial analyses into clinical reports, which will then be returned to doctors as clinical insights. And so that is, so Genomics England has been designed to run clinical, live clinical diagnostics for the benefit of patients. But on the right side, what you see here is our research loop. And the importance of this is that we accredit then researchers and industry partners through a very a robust accreditation process to run research on de-identified patient data to make sure that we can then do very specific research on narrow areas of rare diseases or cancers, and then they can return those diagnostics and therapeutic discoveries on therapeutic developments and diagnostic discoveries back through our platform, and that can be returned into the clinical pathway to improve care in the health system. And so the design of this structure is inherently translational, and the intention is to return a result to NHS patients through improved diagnostics and therapeutics. It's to return a result to the NHS through stratification and better management of care, and also return a result to the UK by increasing R&D and better healthcare overall.
Oh, amazing, amazing. Amazing that you have this functioning well. But I have a question. On one of the topics you mentioned in the first, let's say the first part of the loop, it's regarding the workforce, specifically the physicians and the teams doing the sequencing and the analysis, the panels, etc. How does that flow happen? I mean, and also the training, the education, are the physicians, let's say, able and knowledgeable on what to prescribe and request, and also on the way back, when the doctors report back to the patients, is there training involved? Is the workforce well connected with this vision as well?
So we have done a huge amount of work on, so we do have very expert a clinical workforce in a narrow group, so that there are a certain number of clinicians who were already very expert in genomics. Okay. But one of the ambitions of the NHS is to mainstream genomics and clinical diagnostics into the NHS. So one of the ways in which we make sure that that happens is by having something called the NHS Genomic Test Directory, which means that there are a set number of tests which are reviewed every year, and clinicians can look at the tests which are relevant for their patient, and these are funded on an equitable basis across the whole of the NHS. And this means that it's much more straightforward for clinicians to know what they can order. In terms of knowing that you order the appropriate test, which I think was what was behind your question, then there is something called Health Education England, okay. And they have been running very targeted and effective genomic training across the relevant parts of the health system, from medical student all the way up the system, to improve recruitment. And we now have 70 hospitals which are ordering tests on a repeat basis, and that has increased on an exponential curve as this training has been rolled out. So we can see its effect. Okay,
very good, very good. Another topic that you mentioned, which is I deem very important here, is all about the data. Of course, 250 gigabytes per patient of just the genome sequencing is a huge quantity. But how about the infrastructure? You mentioned it's the largest pool of data as well gathered in the world, right? If I'm not mistaken. How's the infrastructure around data? What platforms do you use? And how do you look at cybersecurity and especially guaranteeing the anonymity or de-identification of patients when providing this for research?
So we discussed this a little bit yesterday. We take very seriously our responsibility to patients, and we have a trusted research environment. I wish you had this slide for us to put up, but we put the data into an AWS workspace in the cloud, and this is a very secure environment. And the result, and in addition to that, this operates within a very effective data legislation environment in the UK, which we meet, and that is a standard across the health system. In addition to that, we have a very effective consent structure. So all patients who come in from the clinical environment, if they are to go into to consent to have their data involved in the research environment, they must consent for research separately. Okay. And we find that this is a very motivated group of patients. They are they care about discovery and new therapeutics and new diagnostics. So 98% of the patients coming through the Genomics Medicine Service consent for their data to be used for research. And in addition to that, one of the key measures that we have for ensuring that those who access our data and use our data appropriately is our Access Review Committee. If you are to access the data, you are only allowed to, we call it like an aquarium. You can only take out the analysis of the data. You can't copy the data or take it away. So we allow people to, it's like you can come and look at the fish, you can study the fish, you can draw the fish, but you can't take the fish away. And we're very strict. So if you want to come and to study the data, you make an application to join either our GSIPs, which are for academics, or the Discovery Forum, which is for industry. And then when you have a specific project that you want to do, you come in through the Access Review Committee and they look at whether it's valid, and our participants sit on that. And having gone through that process, there's confidence that only research which is in the interests of participants in the NHS is happening in that environment. And where you have any kind of concerns, it's acted on quickly. So this is how we protect the data. We have the right infrastructure, we have high quality technical people who are curating and making sure that data is well managed, but we also have good governance processes in place.
No, that's amazing, and congratulations on the high level of governance around these topics. Definitely, we have some lessons learned in Brazil here when we start developing this more strongly. Now, moving a little bit to Brazil, you have been here for 2 days. We had the opportunity to meet with some teams and some companies that are looking at genomics here, making it largely available as well, or start to. And one of the topics specifically for Brazil, we have about 210 million people. It's a very diverse population, big country, definitely different types of genomes comprising what Brazil is. So diversity is really something when creating and setting the pool of DNA here for this to work in Brazil. It's something we look at very strongly. I understand you also have a lot of efforts to add diversity, to make that included as well in the set of data of Genomics England. Can you talk a little bit about that? How that part of the project is going? And
yeah, so it's a big priority for us in the UK to diversify our data. We recognise that it's helpful for no one on a scientific or a moral basis if you have genomic data sets which are majority European white ancestry, and this is a problem globally, not just in the UK, and there are efforts going on everywhere, all of us, Genomics England and elsewhere. So our work is, we're working all across the pipeline, and we will continue to do so. And we've done a number of things. The first is we have reached out to communities which are historically excluded, and we've worked on ways to rectify historic challenges, and thought about how we can improve access not only to genomic testing but also improve inclusive research practices. And one of the ways of doing that has been setting up something called Link 23, which is a set of tools and resources to improve research approaches to genomics, and we think that it's open sourced, so we're hoping that will grow and improve the research not only on the Genomics England data set but also on others. We have also done an analysis of the Genomics England data set to understand its comparability, which we think will also improve inclusive research practices. But we're just at we're making progress, and we still have a long way to go, which we recognise. But I very much appreciated meeting a number of your scientists. I know that you have a colleague who is working on a rare disease data set with Albert Einstein, yes. And this is a really important project, and also Gentil, which I think will cover the whole population perspective, and these will be very valuable contributions to global understanding of genomics, and so I hope that they will be supported by the government and by other investors.
Thank you. Amazing to hear, Nicola. On the topic, Brazil, we talked about this before, the Brazilian health system, it's called SUS, right? It's universal as well, very much based on the NHS in England, that Genomics England is part of, so it's part of the government. What you're doing is connected to the universal healthcare provided to the UK population in a universal way. But Brazil is a little different. We do have the universal healthcare system provided by the federal government with the states and cities, but about 25% of the population relies or utilizes the supplemental health or private health through HMOs and a whole big chain of private providers and hospitals. We saw that a lot of efforts in Brazil, they're coming from the private sector. How do you see this interplay between the public efforts to reach the full country versus the private, more entrepreneurial way of doing things and expanding more quickly? How is that? How do you see that going on here? With
well,
your
experience? I don't think I should come in after 2 days and give you advice. But in the UK, we had to run the 100,000. We had to run a huge project in order to provide evidence yes. for the program to be integrated into the NHS. And we had to convince a lot of people, and a lot of people had questions and concerns and anxieties about whether it would be too expensive, whether it would be value for money, whether the health economics would stack up. And, there is a question here about whether you could run, the evidence through your private sector to be then taken up in the public sector. You could perhaps imagine an environment where your 25% private sector could be your innovation engine, and drive uptake of the new technologies, and perhaps provide partnerships, public-private partnerships, which mm-hmm. could then drive uptake as the technologies become more affordable and you develop the health economic evidence for uptake into the broader environment. But it's very important as we do this and we develop these technologies that we do so not only with a mind for innovation, but also with a mind for responsibility. Perfect. And so, you have this division of the public and private here, and I think when those programs are set up, it will be important to think, how will you develop equity, accessibility and affordability of those programs? And having met many of the scientists who are working in both sectors, I do feel like that's very much at the forefront of people's minds. And it's perfectly possible to achieve that in public-private partnership, because none of these programs can be achieved without joint collaboration between the academics who will develop the scientific basis, without the industry who will develop the diagnostics and the therapeutics, which is what you need to translate the scientific discovery into the technologies which will actually treat the patients, and the government who will provide accessibility for the wider population. And in your case, I think private sector sits like the industry who will develop the technology. And you know, there are tensions always between those three parties because there's different interests. But in the environment in which we live today, we have to be adults and we have to work together between all three of those parties, because otherwise the public and the patient does not get the benefit of what we're all working towards achieving.
Fantastic, thank you. Nicola, we visited a few places. You mentioned talking to scientists. We visited a genomics lab here in Brazil as well yesterday. What is your view of where we are? Of course, Genomics England 10 years ago, it's let's say a precursor of genomics worldwide. Where are we right now, and what are the opportunities we have based on lessons learned, things that you have gone through over the last years? How can we take advantage of the path you already trailed to save time and to evolve more rapidly here in Brazil with genomics?
So you have access to a lot of the technologies that we never had already at the beginning of the 100,000. So when I went to visit Flori and look at the technologies which they had available for rolling out through their new genomics diagnostic company that they're about to set up, they have the most advanced sequencing technologies, which means that they will be able to drive down cost and affordability. And this is super important if you want to scale. It's also completely automated, their labs, which means that, again, it will be very efficient for scaling. And this is very exciting. And the expertise is very high here. So I have very good confidence in that. The challenges, of course, that you have here is, I think, from just short conversations, is wider health data, because obviously genomic data and genomic diagnostics is only one part of the picture of the patient's analysis. You need to join it together with your clinical data and your pathology data and your imaging data. And so I think that part of the health system needs to be worked on. And we have had many challenges in the UK working on that, but the technologies now do exist. And so I think your genomic technologies here are very advanced and very impressive. They need to work on joining together the wider data capabilities.
Looking ahead 10 years from now, into the future, how do you see Genomics England impacting patients in science with all these new developments, new technologies, new insights? There's a lot still to be learned about the human biology and genomics. How do you see that impact in the future in therapeutics, diagnostics, and also prevention?
So at the moment, we have strong evidence, which we've just been talking about, that genomic sequencing can clearly benefit rare disease patients. It can eliminate the diagnostic odyssey, and it's very beneficial for cancer patients, where it can help channel you into the right treatment earlier and make sure that you get a better outcome. But what we are at the very foothills of understanding, and we're still developing the evidence for this through the programs that we're doing at Genomics England and our Future Health and other cohorts in the UK, is understanding preventative genomics. And this includes pharmacogenomics, which can help us understand how genetics impacts adverse reactions to medications. And this has a huge effect on health systems. In the UK, 1 in 16 admissions is due to an adverse reaction to a drug. It's horrible for patients and it's very expensive for health systems. In addition to that, we have new technologies like polygenic risk scores, which we're still trying to work out how you would integrate that into health systems. But theoretically, those tests can stratify your risk of different diseases. So it will work out maybe you are at risk of cancer, but not of dementia. I am at risk of diabetes, but I'm not at risk of dementia. And therefore, I would be screened for diabetes and you would be screened for cancer, but neither of us would be screened for dementia. And as a result of that, it's much better than the existing system, where we have a limited number of screening programs because it's expensive, but it's blanket. And so it's inefficient and it's expensive. And so you can make it efficient, but according to your risk. And so we would have fewer concerns. We would know like specifically what we're at risk of, but also we would only be tested for the thing that we're really at risk of. And finally, you would also pick up if you do develop something earlier, and then you could intervene early, and you could intervene in a targeted way according to your specific genomic profile. So that's what some of the technologies that BioNTech and Moderna are developing, which is targeted mRNA vaccines for cancer and other immunotechnologies. And so that's what I think we're looking at long into the future, but we are on the cusp of it.
Amazing, amazing. Nicola, thank you very much for sharing everything you have been doing and your knowledge with us, with the audience. It was really amazing. Thank you so much. And I hope you can come to Brazil again in the near future.
Thank you.
Thank you.